Sanjay sir. He doesn't need any introduction, but he's the director of the Agile Diabetes Clinic Diabetes Care and head of the department of Ruby Hall. Extremely intelligent, yet a very wonderful person. And over to you, sir, for your talk on pre-diabetes and macrovascular disease risk.
Thank you very much, Anjali. I think it's a pleasure to be on this platform. First of all, I would like to thank all the delegates who have been part of this meeting, as well as the faculty who have deliberated some excellent lectures since morning. I'm going to carry this baton forward, and I'm going to speak today on a topic which is very dear to my heart, something about pre-diabetes and cardiovascular diseases. Till date, I think there has been very little said about pre-diabetes because our focus of attention has always been on diabetes and advanced when people come with long-term diabetes and long-term diabetic complications. But I think the story should start much earlier when patients have pre-diabetes, because that's where you can do aggressive intervention. And I'm going to, in the next 20 minutes, talk about why pre-diabetes is important, and we need to start our aggressive intervention right there. We know that 80% of diabetic mortality really stems from cardiovascular or peripheral vascular diseases. Most of the hospitalization that occur in patients with diabetes are for cardiovascular reasons, and more than 50% of patients with newly diagnosed diabetes have coronary heart diseases. And if you look at this data from the Framingham Heart Study, and they've looked at the risk of cardiovascular disease in subjects with and without diabetes, then you do notice over here that cardiovascular disease events, or strokes, claudications, cardiac failure, all of them are very high in terms of occurrences in patients with diabetes. And if you just put this together, this study by Selby, which figured about more than 1 lakh of patients in managed care enrolls, you do find here that only a small fraction of people, less than 10%, have diabetes alone. And if you look at the long-term patients who have diabetes, you realize that more than half the population will tend to have a conglomeration of hypertension, dyslipidemia, and diabetes together, which actually forms the nidus for development of cardiovascular risk and cardiovascular diseases. We are familiar with the metabolic abnormalities associated with type 2 diabetes. Patients do tend to be insulin resistant. They have high triglycerides, which are the basis for development of liver and pancreatic fat. And we've had a lot of discussion in the morning from excellent speakers about this. We do tend to have low HDL and an increase in small LDL particle concentrations. But I think the entire focus is more on the relationship of diabetes and obesity. Now, here I'm going to look at basically two models where you're looking at the precise phenotyping of prediabetes to help to improve the stratification of disease risk, and how basically just weight and the level of diabetes determines the risk for cardiovascular disease. And here I'm going to look at the prevalence of insulin resistance, insulin secretion, NFLD, and visceral obesity by weight. And if you look at the first upper diagram, let me get my pointer up. So if you look out here, we are looking at three models. One is normal weight with prediabetes, overweight with prediabetes, and obesity with prediabetes. And here looking at 4 parameters of care, where you're looking at NAFLD, visceral obesity, insulin secretory failure, and insulin resistance. For the same 4 parameters, just by the level of weight, you realize the increase exponentially of the cardiovascular risk, just the overlap that you see over here. And if you see the overlap in patients who are normal weight at 6%, the moment you're overweight, it becomes 24%. And if you're in the obese category, it increases to 53%. Now, if you look at from the glucose status, then you see, you're looking at 3 sort of classes of people: impaired fasting glucose, impaired glucose tolerance, and a combination of IFG and IFT. And the same overlap, if you see over here, there is an exponential risk when you have a combined IFG and IGT to almost 64%. What you read over here is, of course, that while the intervention for obesity is important, it is also important that we not only look at fasting glucose as a point of aggression, but we have to look at a combined fasting and post-meal glucose values when it comes to reducing the overall cardiovascular risk. Now, in this entire maze of different risk factors for ultimately development of macrovascular complications, broadly, you do find that visceral adiposity, inflammation, hyperglycemia, hypertension, dyslipidemia, all sort of tend to make the entire conundrum for development of macrovascular risk and complications, which we are going to talk about in a short while. But if I have to summarize my earlier slide, you do see here that insulin resistance, hyperinsulinemia, and hyperglycemia become the basis for vascular dysfunction, more specifically endothelial dysfunction, which ultimately through multiple pathways of inflammation, gene expression leads to atherosclerosis and arterial stiffness, which then lead to increase in cardiovascular risk. We've been talking about a lot about inflammation and inflammatory markers, which are the pathways. And we do know that one of the pathways for type 2 diabetes is the inflammation pathway. And this sort of correlates very well with obesity, which also sees an increases in free fatty acids and ROS levels. And the two contribute more towards contribution of atherosclerotic changes and development of macrovascular complications. So there has been interventions which they've looked at in population which have got obesity and weight gain, and they compared it against patients who are lean and exercising. And if you can intervene by attacking the inflammatory pathway, then can you make a difference in development of atherosclerotic cardiovascular disease? And you've seen here that there are studies which have looked at this, and they have found some benefits in this entire in this blocking of the pathway of inflammation. They've done it through multiple ways, whether it's through pharmacology or by nutrient restriction. And you find that there could be some takeout here for the future where we can research more and see, can these be the pathways for intervention? This is a very good slide that I always love to see. While we know that good control or tight glycemic control earlier on in the case of patients with diabetes does reduce long-term microvascular complications. But what is important to know is the whole cardiovascular risk profile that patients tend to have very earlier, which have an overlap for development of type 2 diabetes. So if you look at genetics, weight gain, dyslipidemia, hypertension, and these are all also sort of risk factors for development of prediabetes. And they have a very common soil hypothesis where cardiovascular risk and type 2 diabetes have very common risk factors. So you have to intervene earlier on, right in prediabetes, when it comes to, you can't do much about genes, but yes, weight gain, dyslipidemia, hypertension are all potential modifiable risk factors that we can intervene. And this should happen right at the stage of prediabetes and not when over diabetes tends to develop. This slide from Ralph DiFranzo is an excellent slide which looks at basically the hazard ratio where they've compared normal, impaired fasting glucose, and known diabetes. And you can see here that there is an exponential increase in the hazard for development of cardiovascular risk. And these are all manifest from the same cardiovascular risk factors, and that's dysglycemia, dyslipidemia, hypertension, obesity, physical inactivity, insulin-resistant, coagulant state, endothelial dysfunction, and inflammation. And if you see these slides, the graphs, you find that the separation occurs much earlier. So the hazard actually starts right at the time of diagnosis of prediabetes itself, and it only broadens out as time elapses. So it is important that we start earlier our intervention. It's not only good to look at only fasting plasma glucose, but you also have to intervene for postprandial plasma glucose too. This study in the Epi-Norfolk study, and what is interesting is they compared both men and women, and they looked at all-cause mortality events and against coronary heart disease and cardiovascular disease events. Now, if you assume the fact that 5.7 is the normalcy, you do find that the risk for development of cardiovascular disease occurs much earlier, even within the normal range. So the cardiovascular risk actually never becomes zero. What is important is to identify the population of people who are going to be at future risk for development of cardiovascular disease. You could have potential people who are at a risk for diabetes. And if you can find out the potential intervention for cardiovascular risk factors, then you should not wait for somebody to develop a rise in their A1C values to think that should I intervene now? the entire process of intervention should start much earlier, even within the normal range of HbA1c values. This has also been supplemented by various other studies. So if you look at patients who are known diabetes at baseline, where they have an A1C, a fasting glucose concentration of more than 7 or less than 7 millimoles per liter, you find that there is a clear increased risk. But patients who have no known diabetes at the baseline, and here you're looking at less than 3.9 to 5.6, all the way up to more than 7, you find that even within the normal range, you have an exponential increase in the cardiovascular risk till the time that they tend to develop overt diabetes. This was another paper from Coutinho et al., and they looked at basically the glucose levels and the risk for cardiovascular events based on fasting and 2-hour post-meal glucose values. And again, you see here that the risk starts much earlier, even within the normal range of glucose values. And the separation occurs quite early when you're looking at the different risk factors that allows you to see that intervention should start early. This was the data from the Nurses' Health Study, and they looked at the risk of myocardial infarction or stroke according to dysglycemia studies. So if you look at the index of non-diabetic patients, which is 1, you see that the index almost becomes 2.5 times before the patient is diagnosed to have diabetes. And then, of course, after the diagnosis of diabetes and the presence of diabetes at baseline, the risk tends to multifold to almost 3 to 5 times. So the risk is never 0 at the time of diagnosis of prediabetes, and hence your intervention for cardiovascular risk should start much earlier at the time of diagnosis of prediabetes itself. Now, here's the definitions of prediabetes by various societies, and I'm just going to leave you to read to that. But what is important is that irrespective of whatever definition of prediabetes that you take, and this was basically the association of prediabetes and risk for all-cause mortality, composite cardiovascular disease, coronary heart disease, and stroke in the general population. And you find that all of them in this forest plot, you find that the risk increases with prediabetes. And similarly, the same risk, if you look at patients with atherosclerotic cardiovascular disease, again, the A1C values are plotted as per the prediabetes. You find the risk for all these endpoints, whether it's all-cause mortality, composite cardiovascular disease, coronary heart disease, or stroke, all increases in the prediabetes population. Now, here they looked at risk scores because you need to have some kind of an assessment for cardiovascular risk, and we more often than not fall back on various risk scores. So you've got the Q risk score, you've got the ACC, AHA risk scores, and the SCORE3 risk scores. Now, irrespective of whichever risk scores that you follow, here you've got 3 populations of people: the normal, the prediabetes, and the undiagnosed diabetes population. So you find over here that adjusted or unadjusted hazard ratios do tend to increase in reference to normal in the prediabetes and the undiagnosed populations. And this is not really specific to any gender. The same group, only thing probably in the males it occurs much earlier, in the female gender it is a little delayed. And same thing again you see here in this paper where they looked at composite of cardiovascular disease, coronary heart disease, stroke, and all-cause mortality. And irrespective of how you really determine prediabetes, the risk tends to increase in the prediabetic population. Now, what I'm going to talk about is the 5 alarming facts of cardiovascular disease in India. We tend to have premature atherosclerotic disease, 10 years earlier onset. Comorbidities like diabetes and hypertension strike at a younger age. Greater prevalence of left ventricular dysfunction at presentation. We have smaller arteries, and this will be evidenced by all the cardiologists who do interventions. And we have difficult PCI and complex CABG surgeries. And this is how majority of our patients tend to present in diabetes. So you have prevalence of almost about 14 to 21%, which present as coronary heart disease. In 19 to 26% patients present with heart failure. In 16 to 29%, there's a peripheral arterial disease. 8 to 10% present with strokes. And then, of course, you have microvascular complications, retinopathy, neuropathy, and nephropathy, which occur in almost about 30 to 60% of our populations. So while prevention of microvascular complications are determined by A1C reduction, the prevention of cardiovascular disease is driven by multifactorial interventions more than A1C reduction itself. And this was well validated by the Accord Advance and the VADT study, where we said that it's important that we need to identify our patients with diabetes early because of legacy effect. So if we can sort of intervene early, we may have long-term benefits. And that's why lowering the A1C to less than 7% reduces the long-term risk of microvascular complications. But not only that, intensive glycemic control with all the other cardiovascular risk factors also reduces the ultimate cardiovascular risk that may happen in patients. We know that from this study that the microvascular complications in early studies have all been benefited by early aggressive control, but the long-term benefits are been proven in patients who have intervened early for diabetes control or blood glucose control. But the same is not true when it comes to macrovascular complications and mortality data. So whether aggressive only glycemic control results in reduction in macrovascular complications has not been really determined. What has been determined is that we need to have multiple risk interventions which benefit the cardiovascular risk in the long term. How do you identify high risk? So while we know the traditional risk factors, age, sex, family history, smoking, hypertension, and lipids, but there are other factors that we need to keep in mind: the duration of diabetes, low GFRs, metabolic syndrome and its components, severe hypoglycemias, NAFLD, NASH, and OSAs have now become important risk factors for cardiovascular disease. We've had a number of intervention trials, the cardiovascular outcome trials by various pharmaceutical agents, which have told us that while earlier we were looking at just cardiovascular safety, we are now looking at aggressively, can these agents in the long term benefit in terms of outcomes, primary or secondary outcomes, where MACE outcomes are concerned, heart failure, cardiovascular mortality, or all-cause mortalities. So the guidelines have now changed that after lifestyle modification, metformin, we need to look at the various comorbidities the patients may have or the patient phenotypes. So if the atherosclerotic cardiovascular disease predominant, we know that the choice of agent is GLP-1 analog followed by SGLT2 inhibitors. If heart failure or chronic kidney disease predominates, we would go more with SGLT2 inhibitors followed by GLP-1 analogs and other agents. If a patient is at a high risk for hypoglycemia, then we know that patients will be more stable with either DPP-4, GLP-1, SGLT2, or TZDs, and so on and so forth. This was basically the most important study. We've had a number of intervention studies and the benefit that should we intervene one risk at a time or should we do multiple risk interventions? And we can see over here from these various studies that if the patient has single risk versus multiple risk, the risk for cardiovascular disease exponentially increases. So it's not just good enough that we should try and intervene with only one risk at a time. We should do multiple risk interventions, which have shown the benefit in terms of overall reduction in the cardiovascular disease. We've had the InterHeart study. We've had the Steno-2 study, which have all proven this various points. And I'm just showing you these various studies, which have shown that we need to intervene at multiple risk factor level and not just probably intervene at single factor levels. So I'm going to end up with my last slide, that how do we really interpret data today? So while patients with diabetes are at increased risk for coronary heart disease, how good is the data? There's no question the data is very good. Are all patients with diabetes to be treated as coronary heart disease equivalents? That's questionable. We don't have any convincing data about it. Can we identify populations of patients which need more intensive care for aggressive intervention? Sure. Look at the age, the duration of diabetes, is the lifetime risk versus short-time risk? What is the total risk burden? And determine the coronary artery calcium scores. And what is important is, should all patients be screened for coronary artery disease because it should have benefit risk ratios? So you have to identify which are the population of people which would need an aggressive screening for coronary artery disease. And these are the very set of populations where prevention strategies need to be put into place. Thank you. And I think the last slide I would really like to put this as our take-home message is, the cardiovascular risk assessment in pre-diabetes is identifying hyperglycemia, obesity, encourage physical activity, aggressive control the dyslipidemia, manage the hypertension well, because we know that overall the clock starts ticking much earlier. And if we want to save lives and prevent coronary heart disease, we need to intervene much earlier than what we do in later parts of life. Thank you very much for your patient listening.
Thank you, Dr. Agrawal.